Well, good evening, and many thanks for the invitation to participate in this event this evening. So what I wanted to do was just talk briefly about NICE, and then link to the What is Health theme, talk about how we attempt to sort of capture health-related quality of life and how we use that in our work. So just a little bit of background from NICE. So we were established in 1999, so we've just celebrated our 20th birthday. I've been lucky enough to be with NICE for about half of that journey, so I've been with them for about the last 10 years. And when NICE was set up, it was aiming to reduce the variation and availability in quality of treatments. People often referred to the sort of postcode lottery, and NICE was intended to sort of help with that. And it was also to help resolve uncertainty about sort of which medicines and treatments are sort of the best use of value for money for the NHS, the best use of sort of limited resources. And if we fast forward 20 years, NICE is now quite a large organisation. We have about 600 staff, about 2/3 of those up in Manchester, in a big office in Manchester, and about 1/3 of those in London. And we've got pretty diverse portfolio of activities across clinical care, sort of so health, public health, and also social care. So social care was added to our remit in 2013, and there's quite a range of guideline products that we produce, and we also produce sort of appraisals on new medicines, guidance on new medical technologies, interventional procedures. That's a program that's been running for most of the existence of NICE, and that's more about the safety and efficacy of surgical procedures. In addition to that, we do provide some sort of advice products that are not sort of formal guidance with recommendations to the system, but more useful summaries of evidence that can help local organisations with their own sort of decision making. So that's just a sort of general portfolio, and what we try to do is make sure that we're using the best available evidence. We make full use of expert input. We make very extensive use of patient and carer input into our work. And the actual decision-making bodies are not people like me who work for NICE. The decision makers are very much our independent advisory committees. We also understand that our sort of work is quite important, and it can impact a lot of people and a lot of patients. So the ability for people to input to that through our consultation processes is very important. We regularly review our guidance, and we really try very hard to be as open and transparent as possible, and to take account of sort of social values and equity considerations. I hope I'm not out of time already. So I just want to talk a little bit about sort of clinical and cost effectiveness. So we very much look at the clinical effectiveness, and we do take account of cost effectiveness in the sort of interventions that we look at, whether they be within a clinical guideline or a specific piece of guidance on a technology. The processes that our advisory committees use are very much deliberative processes and take account of a whole range of issues. But cost effectiveness is an important one, and one that we've always taken account of. And I think it is important that we consider cost effectiveness, and that's really to make sure that the users of the NHS get maximal benefits from limited resources. And in performing our sort of health economic analyses, that does require us to have some sort of measure of health-related quality of life. And that's what I'm going to spend most of my slot talking about this evening. So there are really two questions that we ask. If for example, we're evaluating a new medicine, the questions that we're asking is how well does the technology work? How well does the medicine work compared to the current standard of care in the NHS, so compared to established practice in the NHS. And then the other question we ask is how much does that course of action cost compared to the current standard of care in the NHS? And it's important to note that that doesn't mean it's the cost of the medicine, it's the cost of the whole care pathway. So sometimes you might find that an expensive medicine saves lots of money elsewhere and ends up not being very costly in the context of health economic analyses. So it's the cost of, it's all comparative to the standard of care we currently have in the NHS. So we have a fairly simple concept, and the realities of it are quite complicated, and there's a whole science of sort of health economics. But there's conceptually it's relatively simple, and the starting point being that most useful healthcare interventions are likely to either improve the quality of life or increase the life expectancy, or potentially both of them. And we have this unit called the Quality Adjusted Life Year, or the QALY, and that's really just a sort of measure that combines the quality of life with the length of life. And what's important about it is that it tries to be applicable over many different technology types, many different disease areas on a sort of level playing field. And that's really quite important because, we in making decisions around the use of limited NHS resources, it is important that we can compare these different types of interventions on a level playing field. Now, I've gone and pressed the wrong thing. I'm glad I got that back. So part of the sort of estimation of health-related quality of life is the determination of a utility value, and that's a value between 0 and 1, with 0 being death and perfect health, or sort of full health, being 1. So a QALY could be enjoyed by a patient in full health for 1 year. Equally, if a person had reduced quality of life, so their quality of life was at 0.5 or 50%, then 1 year in that condition would be equivalent to half a QALY. And as I mentioned, the term we use for this measure is the Quality Adjusted Life Year. So just to sort of try to illustrate that a little bit more. So let's say, for example, that there's an existing treatment in the NHS, and on average that extends patients' lives by 2 years, and during that time, their sort of health utility, the health-related quality of life is at 0.5. So if that's our starting point, and then there's a new intervention that NICE is looking at. Now, this intervention, let's say, doesn't extend life at all, but for that period of time, the health-related quality of life goes up to utility value of 0.8 instead of 0.5. In that situation, we would have 1.6 quality-adjusted life years, so that would be a QALY gain of 0.6 quality-adjusted life years. And then when NICE is doing its sort of economic analyses, the other part of the equation is that we sort of determine cost per QALY. And that's one of the key considerations that taken account of in NICE technology evaluations. Just to illustrate it again, so the same starting treatment, but this time the new treatment not only improves the health-related quality of life, but it actually extends life by a year as well. So this time, the old treatment was 1 QALY, the new treatment is 3 years at utility value of 0.8, so that's 2.4 QALYs. So the sort of QALY gain is 1.4. And what we're trying to do, and again, in the health economic analyses, we would work out whether the sort of the overall cost of the care pathway, including the price of the new medicine, whether that was acceptable in terms of cost per quality adjusted life year. Okay, so I haven't yet talked about how we actually measure the health-related quality of life. I've tried to introduce the concept of the quality-adjusted life year, but I want to just close by talking a little bit about measuring the quality of life. I just wanted to introduce one tool, and this isn't the only tool, there are many tools, although this is one that NICE does make extensive use of, and it's called the EQ5D. And the EQ is basically because it comes from the Euroqual Research Foundation, and the 5D stands for the sort of the five dimensions. And these are the sort of key 5 dimensions of health that are picked up in this instrument. So it's mobility, the ability to undertake self-care, to go about your normal life with your normal activities, pain and discomfort, level of pain and discomfort, and also sort of anxiety and level of anxiety and depression. And I think you can see from that these are, these are quite general things, and these are quite general things that probably would apply across a lot of different sort of disease areas and also across a lot of different health technology types. This is just one form of this EQ5D instrument. This is a form called the 3-level, where respondents to a questionnaire are asked to give themselves to rate their health at that moment in time, against the questions in this questionnaire. And again, I think you can sort of see that most people could probably apply this, whether they were feeling really well or not feeling particularly well. And I think it does sort of work to some extent across different diseases and certainly across different sort of health technology types. Now, in this particular case, we end up with a health state of 1, 1, 2, 3. So based on the boxes that were ticked there, the person responding in this case came up with a health state of 1, 1, 2, 3, 2. And of course, that's quite an easy instrument to use, and that type of instrument is used quite extensively in sort of clinical studies, and NICE certainly encourages that type of instrument is used in clinical studies to generate the types of information we want. But how do we go from that to this sort of utility value, this number between 0 and 1 that I've talked about earlier? And basically, it's converted into a single utility value by applying a formula, and that formula attaches weights to each of the 3 levels. In the case of the instrument that I showed you, each of those 3 levels in each of the 5 dimensions. Now, that formula was derived for the UK through a survey of the views and attitudes and preferences of over 3,000 members of the UK general public. And the survey participants were asked detailed questions about how much length of life they would hypothetically sacrifice in order to gain greater quality of life. So that's the basic way in which the sort of formula was derived. So I guess that's probably my time up, and that was what I wanted to cover in my opening remarks this evening. Thank you.
Thank you very much. And so we'll pass on to Dave. Yes, thank you.
Thank you. Okay. So one of the things I wanted to talk about and explore is almost the relationship between health and illness, and healthcare, because we often talk about them as if they're relatively synonymous. And what I wanted to do is that I wanted to get a sense of where the audience is at the moment. So what I'd quite like you to do is, in a moment, I'd like you to raise your hand if you feel at the moment that you are very healthy, so that you have no colds, no coughs, no chronic diseases, no joint pain, no headaches, no toothache, that you are absolutely, completely absent of any disease or any ailments at all. How many people in the audience would identify as that, who are prepared to do some audience participation? Okay, so I think it's about a third of the audience. And it's quite interesting that if you actually look globally and you look at the statistics across, if you ask that question over a whole year, only about 5% of the world's population would say that they've spent a year having had no disease, no illnesses, no infirmity, no physical ailments. And that's just where we're talking about physical health. And so there's a really interesting question of, well, what do we mean by healthy? You know, we're a relatively developed country. We've got quite high levels of income. We'll come on to that later. And yet, in this audience, about 2/3 of people are not in a state of physical health. And there's some global statistics where you actually look at all the things that start to add up. So you look at HIV and AIDS, you look at, obviously, cancers, respiratory diseases, and so on. And the UK is about a third of the way down. And so even in countries where you think there's quite high levels of health, when you actually start adding up all those various diseases and all those various ailments, you suddenly realize that actually they affect huge amounts of the population. And I think that's really important when we start thinking of what we mean. When I trained as a nurse, this was the sort of thing that we used to regurgitate in all our essays. The World Health Organization, when it was first set up, I think in about 48, it defined health as a state of physical, mental, and social well-being in which disease and infirmity are absent. So we're very much drilled into us that it's not just not being ill, it's a state of physical well-being, it's mental well-being, it's social well-being. And yet it's quite interesting when we actually look at that ourselves, that applies to very, very, very few of us. And that has real implications when we start thinking about healthcare. You know, is the purpose of healthcare, is the purpose of health, and when we look at it, is it simply avoiding death? And for quite a long time, it was about stopping people dying. Or is it reaching this sort of nirvana state that actually very, very few of us ever exist in? And in reality, I think there's a continuum, and I think the thinking has shifted about interventions that are very much focused on stopping people dying, to then stopping people having very debilitating chronic illnesses, to now there's a lot more attention on how can you promote physical health. And yet there's real pressures, both politically and socially, in making that happen. So this is a kind of historical perspective. This is mortality. So this is the average life expectancy, starting at about 1500. And if you go through to about 1900, the average life expectancy stayed fairly static in the mid-40s. So about half the audience would be dead, I think. And then what you see is you see a very dramatic shift from about the 1900s that applied across most countries, and you suddenly saw life expectancy increasing for a whole variety of factors, and that life expectancy is kind of climbing relatively steadily. And what I wanted to do is, and my son would never forgive me if I actually managed to lecture at the Royal Institute and didn't do an experiment. So I'd very much like you to bear with me on this. I would like you, if you're able to, if you're comfortable, just stand up. Thank you. So what I would like you to do is I would like you to remain standing if you don't smoke. So if you smoke, if you could sit down. If you don't smoke at all, if you remain standing. This is quite interesting. When I do this to audiences, nurses and doctors, I lose about half the audience at this one. Okay, so we're doing quite well. Okay, remain standing if you drink less than 21 units of alcohol a week. That's about 2 glasses of wine an evening, I think. I should point out the only reason I'm standing at this point is because I'm actually divvying the lecture. Okay, so we're starting to lose a few people. So remain standing. If you exercise, you do aerobic exercise 3 times a week. So about 20 to 30 minutes of aerobic exercise 3 times a week. This is usually where we start. Okay, we're doing very well. There's only one final question now. Remain standing if you eat 5 portions of either fruit or vegetables every day. And for those of you who remain standing, can you feel the enmity and the scorn from, you can sit down now. Thank you very, very much. That's actually about the largest percentage in any group that I've seen. So I would say about a tenth of the audience, about 15%, did all of those four. And yet, this is an incredibly well-educated audience. You would be incredibly patronized if I stood and I told you that smoking's bad for you, or drinking's bad for you, or exercise, or you all know this, and yet you don't do it. And there's a very interesting, and it's a very complex relationship. And one of the things that's I've realized over the years is that knowledge alone does not change behavior. And I get very frustrated when people think, well, the answer to a behavioral change is a poster campaign or warning labels. Not to say they have no impact at all. Most people who smoke know it's bad for them. Most people who don't eat healthily know it's bad for them. And this is the thing I want to come back later into kind of what does it mean around the role of the individual and the role of society around in health. So in terms of healthcare in the UK, this is roughly what people do when they're ill. So when you're ill, about 15% of people will end up as an inpatient in a hospital. Just over 20% will end up as an outpatient. About 40% will access some sort of community service. About 60% will see their GP, and about 40% will self-medicate, either because it takes you a month to go and see your GP, or because you think it's a cough, it's a cold, it's something I'll go to Boots or Superdrug or whatever. What's very interesting is when you compare that graph of where people go to where the funding is. So this is the breakdown of NHS funding. So 49% basically gets spent on hospital beds. The rest then largely gets spent on hospital outpatients. And by the time you get to the bottom, when you look at it, at spending around populations, it's actually very, very small. The vast majority of healthcare spend is spent on very acutely ill people. And I wanted to pick up a point because I didn't want people to get the idea that says, well, this means there's infinite demand. You know, we've shown that a lot of people are ill, that there's infinite demand for healthcare. One of my lecturers once just very accurately pointed out that's not true. If we look in this room, if every single person in this room broke their leg, it would be a finite number of legs. There's only a finite number of broken legs that can possibly happen in the UK. There isn't infinite demand for healthcare. And there's a lot of political discussions, and I'll come on to that with a kind of big and a small p later in terms of what that means. But when you look at what impacts health, and this is very, very well studied, that what we tend to focus on, what you tend to focus on, is things like general practice and hospitals. If you hear politicians particularly talking about healthcare and improving the health of the population, you will tend to hear announcements about GPs or nurses or hospital beds. Actually, what had a much bigger impact was clean drinking water. And the origins of public health in the UK was actually when they started to look at water supply in London and the relationship between water and cholera, and actually saved a huge amount of lives. That's where the public health movement was born. But again, if you look at what impacts on people's health, housing has an enormous impact. Arguably, the house you live in has a much bigger impact on your health than the availability of primary or secondary care in your local area. Equally, the job you do, not only whether you have a job, but the seniority and how much you earn. That you're in a relationship, that you have money and that you have income, and ultimately about individual choices. So we know that these are all the things that impact health. And then we get onto a very interesting conversation about, well, what is the role of the state? And there's relative unanimity to say, okay, the state has a role in terms of the provision of general practice. It has a very clear role in terms of hospital. It has a pretty clear role in terms of the provision of water. You could argue the toss. But then you get into areas which kind of reflect the political philosophy. And I'm not here to talk about any particular philosophy, but depending on where you are politically, you may or may not feel that the state has a role in terms of promoting employment, whether it has a role in providing housing, whether it has a role in terms of the amount of disposable income you have, whether it has a role in your choices, and very controversially, whether it has a role or not in terms of your relationships. And how would we feel if the NHS suddenly sponsored Tinder? May seem a very strange example, but there's quite strong evidence that if you're a 70-year-old smoker and you give up smoking, the impact on your health and your mortality, the impact on your life expectancy is less than if you're a 70-year-old with no social contact at all and you're introduced to one friend. Social isolation in the elderly has a much, much bigger impact on mortality than does smoking. And yet, I can imagine the headlines now. And in terms of what this means now in terms of the future, I think this is the spend. This is roughly what's spent on you during your life span. So what tends to happen is under about 10, there's quite a bit of healthcare spending, health visitor support, midwifery, school nursing, and so on. And then there's a huge period of time where the NHS doesn't really spend that much on you unless you sort of have an accident or you get ill. And then it starts climbing quite dramatically once you get into the 70s, 80s. And if you look at the statistics around life expectancy, we're getting older. All developed countries now, the populations are getting very old. And this is brought into really sharp relief. So this is from the UN World Population. So in 1950, about 8% of the world's population was over 60. In 2000, it was 10%, and it's projected to be 21% by 2050. Now, if you combine the top graph with the bottom graph, what that then does is it puts a huge amount of pressure on simply the provision of services to very acutely ill people. And if we go back to our original idea that says, well, actually, health is about the absence of illness and infirmity, it's leading a life of social well-being, personal well-being, personal fulfillment, happiness, the absence of infirmity. There seems to be a very, very, very big gap between that and the reality of what we see in terms of health and healthcare. Thank you very much.
If you'd like to give your presentation.
Hello. Thank you very much for inviting me to talk to you about what I think health is. And I think it's quite a philosophical question. And I thought the best I can do to bring to that question is tell you a bit about how health resonates in my life. And health resonates in my life because I am a physician. I'm a pediatrician in infectious diseases. And obviously, through that job, I try and keep children and families as healthy as I can. But I also work in a global health context. So both the decision-making of healthcare within the UK, as well as in the international setting, is what would influence my perception of what health is. And I want to take you through a little journey of how that might resonate with individual decision-making in the context of what I think now needs to be considered as planetary health. And it's a bit of blue sky thinking, but I think as a group of people here, we all make decisions as individuals about our health, behavior changes, or if we eat those 5 portions a day or not. But the implications for the communities in which we live of those decisions also need to be considered when we're thinking about, are we actually a healthy society? And how do we define health on a bigger scale? And I want to give you the first example, which is around our decision-making of something related to vaccination, because I work in vaccine research and I work in vaccines being a fantastic preventive tool for keeping populations healthy. And as you probably know, we've had some huge issues with people deciding that maybe they don't want to take what I consider life-saving vaccines, and they make decisions for themselves and their children that determine to some degree their health, but also have an enormous impact on the community in which they live, because by not vaccinating yourself or your family, you will possibly induce a risk of infection to members of your community who are actually not protected and vulnerable. And that led to, in the UK, for example, our country losing the status of a measles-free country. And globally, we have more than 1 million cases of measles, which is not what we had before. So that's the first example of how our own decision-making resonates much wider with other healthy decisions in the world. So is that healthy behavior? And whose health is it anyway? Do we have a right to make all these decisions about our own health without considering the wider context? And how does that decision-making for health interventions actually work? And here's my second example. So we've heard from NICE and we've heard from individual decision-making, and we've heard about QALYs and ways that interventions might be introduced into health systems. Now here's an intervention for what I would consider one of the most scary diseases in the world, which is meningococcal meningitis or meningococcal disease. I don't know how many people in this audience have heard about meningococcal disease? So quite a few. Many of you might be parents. Many of you know that we now have a vaccine, or in fact, a number of vaccines to prevent this terrible condition. But that vaccine wasn't easy to bring to the place because we had it licensed in 2013, and every parent in the country was there probably quite prepared to give that vaccine to their children. However, the decision process around the vaccination was quite complicated. And between the health economics evaluations and the recommendations of the JCVI, which is the committee that recommends vaccines to the Department of Health, over a year and a half went by when in that year and a half, potentially, some other children could have received the vaccine. So our decision-making for health interventions needs to be informed by, obviously, the QALYs, but also it is probably informed by public pressure and emotion to some degree, because the cost-effectiveness analyses around the introduction of the vaccine were initially very much in favor of this vaccine being not cost-effective. But then, as things moved on, the public pressure and change in the pricing of the vaccine led to the introduction of the vaccine. And similar dynamics can be discussed here for diagnostics and therapies. And everybody knows about certain therapies really being quite expensive, people seeking private funding to access them. And this is cost versus value discussion, I think, is something that we as a society all need to be engaged in. So now we have the vaccine, we have it in England, we have it against hip, which is another form of meningitis, or pneumonia, pneumococcal disease, but we still don't have it globally. And on this graph, which I'm not quite sure I'll be able to show you here, this is a graph that shows the introduction of vaccines against hip meningitis and pneumococcal meningitis and pneumonia in high-income countries, which is 0.0. And you see here the birth cohorts with access to the vaccination went up very, very nicely. And then you can see a delay here of over 2 years of a vaccine that's already proven to be life-saving in low-income country settings. And I think we need to think about equality and equity of access to what we know are interventions that also promote health, not just for ourselves, but for societies maybe placed in other areas. So in order to do that, I want to place the vaccine discussion into the wider context of health systems and what their ambitions might be like. You might know that the WHO has a framework of bringing vaccines to societies wherever they are and people wherever they are. And currently, the immunization agenda for 2030 is being developed. And the vision for that agenda is that the vaccine should be there for everyone, everywhere, at every age. But what's also important is that the vaccines are embedded in health systems. And that's when we talk about health, we also need to consider what these systems look like. So when you look around immunization, for example, in the UK and in most countries in the world, vaccination is embedded in primary healthcare. So you need to have a primary healthcare system that can carry this health-providing intervention. That will only work if you have a resilient health system, because we've seen in conflict situations, for example, where those systems break down, all of a sudden we have outbreaks and the health of people is seriously damaged. There's a big agenda around universal health coverage where access should be unified. And obviously in the UK, we're in a very privileged situation to have that universal health coverage. But again, that's an ambition for a wilder world of planetary health, and that feeds into the Sustainable Development Goals. So immunization in this circle here is just an example, because the concept applies to many other interventions to achieve better health, and be that care for cancer, be it care for chronic cardiovascular diseases, for example. I just pick immunization because that's close to what I work with. So who remembers the Millennium Development Goals? They've only just changed, right? But what is really important that within the Millennium Goals, we had 3 focus areas of very well-defined parameters how we could improve global health. And they related to child mortality, they related to maternal health, and they're related to HIV, AIDS, malaria, and TB. Now, the Millennium Goals have been and gone, but they've been superseded by what's called the Sustainable Development Goals. Now, who has heard about the Sustainable Development Goals? Okay, a few more, good, right, because as you can see, the plot has significantly thickened, and instead of having 8 Millennium Development Goals, we now have 17 goals. And if you look closely at these goals, only one of them is now specifically dedicated to health, which is the one for good health and well-being. And it's not just health, it's also well-being. And the definition that David proposed is obviously hugely comprehensive and a tough one to achieve. But what you can also see that a perception has now come through, and again, that resonates very much with your talk just now, that health is more than just a silo, and it is embedded in education, it is embedded in economy, it's embedded in fighting poverty, it's embedded in planetary considerations. And I think when we're thinking of health now, we're probably not just thinking of a particular product or a particular technology, but a system of how do we bring health to the forefront in our deliberations around these other factors. So I want to, and I didn't know about this talk before, I just wanted to give a few thoughts on what I think are limitations of QALYs, because they measure the value of health outcomes, but it's entirely monetary. And what I've just shown you there is not entirely monetary, it's actually much wider than that. And it assumes that health is a function of the length of life and the quality of life, and how you measure that quality of life is actually probably quite context specific. And if you just look at, a small child growing up in a privileged household in West London compared to an old person who might be sitting in a group of other elderly people in the Gambia in West Africa, where I also work, surrounded by their family, their health might not be fantastic, but their well-being might be pretty good. And the demands that we have to measure the quality of life is actually a very wide scope. And if we're talking about health and well-being, we need to make that a lot more context specific. And it's not just about health. And these measures are not the same. So a few thoughts for the discussion we might be having is, health, is it a right or is it a privilege? How do we deal with, that demand on our systems? We talk a lot about personalized medicine these days, and it's an approach of really trying to bring the best health interventions in a very personalized way, whether we're talking, pharmacogenomics, or we're talking, trying to predict side effects of certain interventions and therapies at an early stage. That is very sophisticated analytical steps that we're taking in healthcare in resource-rich settings. But we need to consider also the impact of the community and in the public in general. So the whole dilemma between the individual and the community and the planetary health, in my view, can and should not be separated. There are definitely trade-offs in health investment because the resources we're having are not going to be infinitive, and the health needs to be seen in the context of planetary health, and I would like to bring that topic up. Thank you very much.
Well, thank you very much. There's three very different and thought-provoking talks. So as they are so different, I just wondered if I could ask each of the speakers what resonated for them in what they've heard from their peers. I'll go to Dave first. What resonated with you from what you've heard from Beate and Nick?
I think I'd never really actually appreciated that as the Millennium Goals had shifted, there were less health. That was really interesting. And actually, when I'm looking at it, I'm thinking that's quite worrying and quite kind of a sad retrograde step. And I think the QALY side, and it was interesting having both sides of it, is a really interesting debate. And I studied health economics back in the day. And actually the idea of can you attach monetary value and can we take a qualitative concept like health and quantify it, I think is a really, really interesting question. And yet without it, it makes it hard to say whether you can, this drug or that drug should be available. But equally, there's an argument that says, well, how does it deal with particularly things like mental health, certain aspects of well-being don't lend themselves to be quantified in as simple a way.
So is it a matter of simply making decisions on which can be quantified and which can't be, and then working out a different way forward for the ones that it's difficult to quantify?
I think for me, it's using the right tools for the right thing. I think certain things like do you give the drug A or drug B, or do you use this vaccine or this screening program, lend themselves to much more quantifiable decisions. When you start looking at things like mental health provision, and who benefits the most and what does success look like, and in some of the chronic diseases, I think it's a lot harder. So.
Okay, thank you for that. Nick, what resonated for you, what you heard?
I think there was lots of very, very interesting perspectives there. I will have to come back and defend the quality, but I'll come back to that in a minute. I mean, I thought in Dave's presentation, I think it was really interesting the commentary on the proportion of spend on people who are ill and versus the sort of lesser spend on preventative. And I think that's a really important point, and I think sort of preventative interventions are critically important. But I also think we end up with a bit of a sort of a moral dilemma as well, because when people are in trouble and they are ill, there is an expectation from themselves, from their families, from the carers that the NHS is going to look after them, and I think there's an enormous level of innovation in the life sciences industry currently that are allowing significant extensions to life and improvements to quality of life, but with very, very innovative but very, very expensive sort of products, and I think working through that's going to be a really big challenge for the next generation. And I think financially sustainable care is crucial if we're going to continue with a system whereby the comprehensive health provision can be provided for all. So I see that as quite a big challenge. Just really quickly on the quality, because I don't want to come across as quality obsessed, and I'm not, but it is a very good instrument, and there are Dave's absolutely right that some things may not be picked up by that very simple questionnaire that I showed you. Although of course mental health dimensions were very much in there, but there are other instruments that can be used. There's disease-specific instruments can be used, and they can then be sort of values can be mapped onto the sort of EQ5D and the utility values that have been generated for that. I think it's really easy to knock the quality, but it's the best we have, and some measure of some way of being able to compare whether at sort of a population level it's going to be better to spend this 20 million on intervention A or intervention B is quite important, and for the reasons I've just outlined around sort of financial sustainability of healthcare, the health economists are right, and Dave, you're a health economist, which is something I can't claim, but the health economists really are right. If you can only spend your money once, and if you spend too much on something because the value hasn't been properly understood, then you haven't got those resources to spend on all the other sort of patients in the NHS who could make very good use of those resources.
Thank you, Nick. Beate, I'll come to you in a second, but just to go back to Dave, because of what Nick just said was very interesting. Can we create financially sustainable care that's comprehensive? He thinks that's a challenge. Do you think is it possible?
I think, I mean, to be honest, I do think it's possible, but it means you have to make decisions about the general level of taxation in the country and then kind of what you spend it on. And then you get into political with a very big P discussions. But I think you could certainly argue the toss that some of the Scandinavian countries have much more comprehensive health and have higher levels of health and well-being than we do. And certainly if you look at America, which is often used as the sort of developed country with the worst healthcare system, you can see how you can make kind of much bigger inroads into it. So I think it's possible, but equally, it's what the country and what people choose to vote for. So I was trying to kind of keep politics gently out of it, but it is ultimately a political, a political perspective.
Beate, did you want to come in on that?
Yeah, I guess, the avoiding death or reaching nirvana picture really kind of resonated with me, because as we as we think about quality of life, I think those, and you indicated or you hinted that you think the goalposts might be shifting a little bit in people's perception there. So this whole issue about how do we measure quality of life, I think will become more and more important as we're also looking at sustainability, not just of our own being, but the being of our children and grandchildren, etc. I didn't want to dismiss the quality. I am a realist enough to think that there got to be some metrics around how we make decisions. And what I just take away from this is that these metrics might be quite different in different settings, because the parameters that you use to populate them are very different. If you use a questionnaire like that in a setting where people can barely read and write, it's already not a way that you can assess whether that will be a good decision-making tool for a government, for example, to say, okay, we'll buy drug X or we're not buying drug Y. So I don't think we have managed to develop tools to the same extent for settings that are not the UK or Sweden. So I think we need to, so that was just reminding myself that I think where the opportunities lie with the qualities, but also some limitations. And Dave, I think you really very nicely illustrated the investment pyramids, the inverted investment pyramids. And that gives us lots of food for thought, because people would rather be happy and healthy in the community than being sick and decrepit on some hospital ward and not being able to go into some sort of home where they will be supported by their relatives, right? So I don't know the answer to that, but those are questions that we were going to have to ask ourselves, especially in the context of an aging population and more overall chronic morbidity and mortality. And that includes the mental health aspects too. It's important to keep those in mind, yeah.
Thank you. And Beate, you say that obviously some of the tools that NICE use couldn't be used in a low-income setting. But of course, NICE generally, it's been lauded as having been copied by many European countries. It's seen as a standard bearer. Are these types of organisations which use these metrics, are they developing in middle income and lower income countries?
In fact, there is a NICE International. It might have been renamed by now, but it's based at Imperial College, and it's trying to use or to adapt the tools that we are using for evaluation to different settings. And they virtually work with a question and then do a series of case studies in the countries, get the stakeholders together and try and sort of change or adapt the matrix that there is in the questions that could be asked. So definitely there are initiatives like that, and any government will have to make decisions around that. Often these decisions come from other committees that have already made a decision. For example, the introduction of vaccines in low and middle income countries is often determined by what the WHO recommends, and then that goes to the local or the community level, and then it would be decided by a committee within the country. They're not going to redo the entire cost effectiveness analysis around it.
Okay, thank you. So just, as I said, I wanted to ask what resonated with you, but do you think there are any common themes between the three talks that you can build from?
To me, the issue of value comes up as a theme that is also reflected in all of our three talks, I think, and the perspective on value and health as a value in society, whichever way you want to look at it.
Nick, do you want to come in?
Yeah, we just apologies for going back to the last topic, but the use of health technology assessment, the type of the sort of more generic sort of name for the sort of things that NICE does, there are, as well as the NICE International that Beate mentioned, that there are sort of fairly major international organisations, like there's ISPOR, the International Society for Pharmacoeconomics and Outcomes Research. And there's also HTA, Health Technology Assessment International, which is a major international group, and they're organised along sort of regional levels, and rolling out the type of approach that is quite widely used. It's not just NICE. There's rolling out that approach in sort of middle income countries is a really major part of the sort of activity these days.
Okay, thank you. Yes, Dave.
I think there's something about how tools help decision makers. And I think the international comparisons are often really interesting. And when you look at the challenges different countries have and how you support what are political decisions. And I think the outcome data is quite interesting, but you also start to get into the territory of what's health and what's not health. Yeah. So certainly if you look at, some of the work I'd looked at in terms of global health said for a lot of countries, one of the things that will have the biggest impact is actually educating girls. Educating girls will have a huge impact on the health of a population, but to consider that health spending, and then people go, is that education? In this country, you can see arguments between, well, is that transport, is that housing? Yet people who live in poor quality housing, but will have very poor health outcomes. And there's often a focus that says it's about the health provision. If you look at London, London has one of the highest densities of big acute hospitals with very high standards and some really amazing clinicians all over. And yet in London, there's some real pockets of incredibly poor health right next to fairly good health. So.
Yeah, thank you. I want to come on to some questions of my own. I mean, what I thought was interesting was you, obviously, Dave, specifically mentioned the ageing population that is facing us here in the UK and elsewhere. So I wondered, what challenges the ageing population has for NICE in terms of quality of life, of many more older people living for longer and wanting a quality of life maybe, in a different way than previous generations, expecting a better quality of life. How is that going to impact, do you think, Nick?
Well, I think in the ageing population, the sort of interface between sort of social care and sort of healthcare, and really getting those interfaces are going to be sort of very important. And I think in terms of NICE's role, the guidance that we're producing in sort of social care as well as healthcare is relevant there. I think the challenge is probably going to more be a sort of challenge for an affordability challenge for society and the NHS. I think the way that we go about evaluating interventions, work reasonably effectively for interventions that are intended for the ageing population. I think there probably are some sort of medical technologies that could be really helpful to sort of assisted living in keeping patients in their own homes, and NICE has medical technology programs, and they're actually expanding as well in order to sort of evaluate those types of technologies, and some of them may well be relevant to the aging population.
I mean, I thought what's stuck in my mind when you were talking about, how much life would people be prepared to give up in order to have a better quality of life. Now that's fascinating to me, and with an aging population too, increasingly relevant. And I'd love to know some insights into what people actually answer, how they answer that question.
Yeah, the tools there are health economic tools, and they're sort of called time trade-off, and it's really a sort of it's a theoretical exercise undertaken with people who haven't necessarily got disease. It's randomly selected sort of members of the public, and you sort of present them with describe a health state. And just say, what would you prefer? Would you prefer to be in that health state for a whole year, or in this full health state for 6 months? And that's the type of approach. It's called sort of time trade-off.
And are these kind of the wider discussions that we need to be having, with people, so they can really get to? You're nodding there, Beate.
I believe so, and I think in general we need to get much more involved in hearing what people actually want, and the examples of people living to the age of 100 but being very unhappy, or the example that you gave, giving up smoking when you're 80 has less impact on your health. I quite like the idea of the NHS and the great. Yeah. I also think we should have delivery for vaccines, right? Yeah. So there are some ways of that you could engage people's demands in a different way, and it ought to be discussed, right?
And I would actually, it really resonates me about kind of community involvement, what's important. I used to chair a community organisation in Salford, and we worked in some very deprived areas, and it was very interesting when we did a stop smoking initiative, and we started talking to a lot of local people, and we said, well, if you stop smoking, you'll live longer. And people were generally saying, why would I want to live longer? Yeah. I lead a pretty rubbish life. I'm not happy. The idea of more years like this makes me very miserable. What was a really interesting intervention was when we pointed out the evidence that on their pets. So if you smoke, your budgie will die younger, your cat will die younger,
Right.
your
All of a sudden, you know,
dog.
it's
And
the
for
context.
those, that was the intervention. And they signed up for programs because they were really afraid of their dogs and cats dying prematurely. But actually, their quality of life very much went against the grain of what we would think, that, well, of course you want to live longer. Some people are saying that's not as attractive as you might think.
It's very, very sad, given that obviously you talked about the World Health Organization definition of health and taking in the, you know, social as well as mental and physical well-being, but that obviously wasn't being catered for in their considerations. And I thought it was interesting, obviously, Dave, that you talked about social isolation in the elderly, which is all linked into this, I'm sure, having an impact on mortality. Again, with an ageing population, what's this going to mean?
Well, and I think also we sometimes have a model that says social isolation is about, you know, a very elderly person living alone in their house. There's a lot of evidence about social isolation amongst younger people, amongst students, amongst a lot of working professionals who people may think, well, you've got people around them, but actually they don't have close, meaningful relationships. And that has a huge impact, not in terms of their mental well-being, but also their mortality. You know, and yet it's a tricky one, I think, for politicians who have a label of, say, health in their job title or department. So, well, actually, why don't you do something about social isolation and loneliness and helping people build relationships? That sits quite uncomfortably with a lot of decision makers.
Yeah. I mean, you know, we obviously have a lot of discussions around, you know, if you look at somebody, can you tell if they're healthy or not? I remember writing stories about obesity and visceral obesity, and, you know, you can't tell a fat person from looking at them necessarily. In the same sense, you can look at somebody and if they're lonely, and that can have an impact on their health. So it's a fascinating issue. I want to come on now to Beate. You were talking about cost and value, and those discussions need to be, society needs to engage in those discussions. Do you want to expand a little bit more about that?
Yeah, I mean, you know, not everything, well, the example that I gave around the meningococcal vaccine, eventually there was such pressure from the public because the product was obviously available, and the health economical model that was put around it didn't actually take into account the impact of dead children on their parents. And once all of those factors were figured into an alternative cost effectiveness model, and the price of the vaccine had been decided with the company to be lower, all of a sudden it was possible, right? So and another example is the introduction of the HPV vaccine for boys. So in terms of preventing cancer in women, it's not going to have the biggest impact. But in terms of equity of access and prevention of ill health in men, it will have a significant impact. And the country could afford to roll out the vaccine for both populations. I mean, Australia did that 5-6 years ago, and it's been taken up very well. So I think that those are the questions between cost effectiveness but value within the society. And I think those are I mean, there are other examples that don't come from vaccines, and I'm sure you have them as well, that we need to debate more, I think.
Okay.
I just wanted to pick up, actually, because I also think there's a danger with cost effectiveness being the main lens, because generally speaking, when healthcare gets better, it gets more expensive. So actually having comprehensive vaccines is very expensive. It means people live longer. The older people live, the more expensive are the things they die of. And medical technology, and it's right and ethical that we do it, but we are actually increasing the cost. I remember when HIV and AIDS, I was a commissioner at the time. You know, it used to be you got HIV, you would develop AIDS within a few years, you'd be dead. You know, it was very much a fatal disease. Nowadays, it's much more akin to diabetes. If someone in the UK gets picked up and treated early, they can actually lead 20, 30, 40, 50-year life expectancies. And now what you're getting is comorbidities of HIV and coronary heart disease, HIV and respiratory diseases, that gets really expensive. But ethically, it's absolutely the right thing to do. But we're increasing the cost that we spend on a person through their whole lifetime, you know, massively. And that is a challenge.
Okay. Well, on that note, I want to open the questions to the floor, to the audience. We have some roving mics, so if you could put up your hands if you have a question for any of the panel.
I think what you're also talking about is responsibility. So in all of this, care, social care versus healthcare, et cetera. Can you define a point, and I think it's very difficult myself, where a person's responsible for their own health and where the state steps in? And do you think that would ever be something that could happen?
Oh, that's a good question. Dave, do you want to kick off? Because you were talking about the state.
Well, I mean, I suppose the obvious example is probably mental illness. And interestingly, most people with a mental illness are at far more danger to themselves and to other people. But it's a space where I think there's acceptance within the clinical community that at a certain point, the state can step in, take away your autonomy, and make treatment decisions against your will. I think it is a slippery slope. And I think, interesting, a lot of the things around smoking, fatty food, sugar, etc. I think there's an attempt to be more of a nudge process, but I think people react quite badly to saying, well, I have the right to do that. But there is a consequence. And actually, vaccines is a really interesting example. Should people have the right not to vaccinate their children is a really hot topic.
Yeah, it's very debated, as is in that same area around the recommendations that Sally Davis made recently, just as she was leaving, that actually there's not enough being done against obesity.
Yeah.
So therefore, sugar tax, all fine, have it now, don't have it in 5 years. And people need to be kind of more forced to lead a healthier lifestyle, right? I mean, and I didn't see lots of people flag waving saying, oh, this is all terrible. Because ultimately, I think people will understand that, some decisions are no longer going to be there. And because the resources of repairing the damage that kind of decision-making has done to their health are not going to be unlimited, right?
So you agreed with her that having snacks on the train stations or train journey should be banned?
Well, I thought it was, she had a number of suggestions there. I would have said, yeah, do it.
I wouldn't necessarily go that far, but I think what is interesting is particularly when you look at some inner cities, that the cost of healthy food is a lot higher than fatty food. And you think, well, you could, through a series of incentives, turn around and say, if you want to have an unhealthy deep-fried meal, that's fine, but it will cost you 3 times as much as a salad.
That's right. You have to reverse
fresh fruit is a lot cheaper than processed food. And at the moment, the economics are the other way. If it's a lot easier and a lot cheaper to eat unhealthily than it is to eat healthily. So.
But for example, in hospitals, you could introduce decent food, right? I see the food trolley come around in the pediatric ward. It has chips, it has baked beans, it has, rubbish food. And we're trying to set an example here. I would like do away with that trolley immediately, except it has Thomas the Tank Engine on it, so that's very nice.
Jamie Oliver was trying to introduce healthy food in the schools, and then there were parents at the school gate passing through McDonald's. I mean, that just... that's a point where you kind of scratch your head and go, well, I'm happy to pay taxes for an NHS, et cetera, because I come from America. I know how awful it is in America. But there comes a point where you kind of think somebody else has to step up to the plate too a little bit, and take responsibility where they can, if they can. I don't know.
Okay, thanks very much. Good question. We've got a lady next very close to you, and then we'll move to the main.
Hi there. Thanks. It's been a fascinating talk. I'm a layman, so I apologise for my questions. I was petrified to see the chart where I clearly am starting to fall off a cliff at the age of 47, and it's all downhill from now. But it made me think about these QALYs. And the question I've got is are all QALYs equal? I'm extremely suspect about your methodology, about how you're working the time trade-off stuff, because I think if I was asked on the street what decision I would make, I couldn't possibly answer it as a healthy person. And I suspect that if I was given a kind of terminal diagnosis, I may have a very different answer. So my question to you is, on the QALYs, is one QALY that you're making all these decisions on in terms of extending my number of years at a poor quality of life, do you weigh that the same as QALYs of improving my quality of life but for a shorter time frame?
Okay, Nick.
Okay, well, there's some fantastic questions there, and I think there's 2 separate sort of questions there, really. So I think one of them is around is around the sort of the methodology of determining determining the weightings that result in those utility values. And all I can say there is that I mean, the example that I gave was the system that was developed by the Euroqual Research Foundation. They've been doing it for many, many years. They've been doing it in many different territories internationally. And, you know, they put a great deal of effort into getting the most valid results that they can get. So I'm probably not a strong enough technical expert to really reassure you on that methodology. I think your other question is, are all QALYs the same? And that's a really, really good question. And in the context of NICE, the answer is largely yes, but not completely. And we weight so in our normal health economic evaluations, we would say that if we were to spend 20 to 30,000 UK pounds on achieving one quality adjusted life year, that would be reasonable use of NHS resources. That would almost be sort of neutral use of NHS resources, because we pretty much buy as many QALYs for the, you know, through that new treatment as would be displaced by not having it to do something else. So we would consider that 20 to 30,000 pounds per QALY to be reasonable use. Now we do have a couple of exceptions to that, and one exception was that treatments that extend life at the end of life, as long as they meet some criteria that are quite sort of, you know, laid down in our sort of methods guide, then we can apply a QALY weighting up to the equivalent of paying £50,000 for a quality adjusted life year in that situation. And another sort of exception is that we have a very small specialist program called our Highly Specialised Technologies program. And that's a program that's really focused on very severe, ultra-rare diseases and interventions that have the potential to really make a very, very profound difference to the quality of life of and the length of life of the patients treated. And in that program, we consider sort of £100,000 per quality adjusted life year to be reasonable use of resources. And there are even some sort of multipliers beyond that for the, you know, for treatments that provide the most profound beneficial impacts to patients. Hope that helps.
Okay, thank you very much, Nick.
Sorry.
Oh, sorry, Nick.
If I
no,
could
Dave, please do.
Yeah, I think, and I wouldn't necessarily want to completely bash colleges, because I remember being in health commissioning in an era where we didn't have NICE, and literally your health authority determined whether you got a drug or not, or whether you got a treatment, because it was down at an individual level, and that was a nightmare to be part of. It's much fairer. I think there was some good examples there. I don't think QALYs are treated necessarily equally, and I think by most analysis, if you think of that inverted pyramid, if you shut down a big teaching hospital and you ploughed that money into vaccine programs supporting young mums, teenage mental health programs, you would achieve dramatically bigger increases for your health and well-being than you would by running a specialist teaching hospital. But no politician of any political persuasion at all is going to stand up in their constituency and saying, I'm shutting a hospital to support lower level intervention programs. So I think there is the science, and then there is what I'd call the fudge factor, which is like, well, we have to price those QALYs up, otherwise we end up saying no to very expensive treatments that very powerful lobbies are pushing for. And there's other interventions that are more community and primary care and public health orientated that don't have as strong lobby groups fighting on their behalf.
Yeah.
So.
Can I just really quickly come back in? And I actually agree with a lot of what Dave's saying there, and And of course, it's not just the science and the way we determine quality-adjusted life years. There's the sort of broader policy, and NICE over the years has very much seen itself as a facilitator. So Beate talked about the price of the vaccine coming down. And increasingly, NICE is working very closely with the commercial colleagues in NHS England. And the sorts of analyses that we're doing are resulting in commercial negotiations that result in better value. So if we want sustainable healthcare, financially sustainable healthcare, and we want the best new products available, then these types of analyses supported by the sort of appropriate commercial discussions with companies and the appropriate sort of managed access arrangements, that type of thing, it does mean that so far, the NHS has been very successful at making the vast majority of innovative new products available to patients, and I think we've got to remember that it's not all about the sort of science and qualities. There are sort of commercial dimensions and commercial negotiations are part of this too.
Okay, thank you. Let's move on to the next question. Gentleman in the middle there.
This is the worst kind of question. I'm going to ask you for a forecast. At the beginning of the Royal Institution, obviously, a definition of health and the role of the state to Bentham or John Stuart Mill would have been different to what it was tonight. 100 years from now, what do you think a definition of health, perfect health would be, and the definition of the role of the state? And I'm thinking in terms of that science fiction novel, Logan's Run, where there is perfect health for everybody, but you get to live till you're 30, and that's it. And the state basically take you out without telling you, which is a pretty severe example of what the role of the state would be. But what do you think this kind of change would be over the next 100 years or so?
Okay, the future of health in 100 years. Who wants to kick off with that?
You never ask the easy questions. Well, I mean, my eye is much more on the global space than it is on the national space. I would very much hope that the overall quality of life for, actually young people in those settings is significantly better than it is now. And the whole issue of what happens with, longer term survival, and we're actually going to have to face that in low and middle income countries as well, because the life expectancy is going up. I would be surprised if the decision of governments would be to put their money into the older population before they've lifted, the well-being of the younger age ranges. That would be my bias.
Thank you. Dave?
I think probably the biggest impact, and I think it might be within the next 50 years. I'm always conscious, I was talking about predicting the future of health, and I said, well, 25 years ago, we didn't really have Facebook or the internet or Google, so if we were trying to predict the future, it would look very different. I don't think there'll be such thing as a randomized control trial. I think that we are not that far away from, at a very early age, you will have your gene mapped. We're down into the tens of pounds now to have that done. And what you, I think, are quite likely to have is a roadmap of where you're likely to develop illnesses, and you will get personalized drug treatments. They're very expensive at the moment, but you can see a point where it says, okay, you have this condition, and we've put your genes into this process, and we've built you a tailored drug, which actually would then remove the need to say, well, the same drug isn't being administered to 10,000 people. 10,000 people are getting an individualized drug. I also suspect that you will get quite an increase in health inequalities, though, because I don't think we as a system would know what to do if someone said, we've got an absolute guaranteed cure for cancer, £10 million a hit, NHS, off you go and work out what to do with this. We're sort of getting away with things because things aren't perfectly effective, there's other things. But I think, and I could see that happening within the next 50 years, if you look at the rate of genetic medicine and the rate of tailored pharmaceuticals.
What do you think that would do to our mental health? if you had your pathway mapped and, okay, it's very nice to know that you should maybe have this beta blocker because something else is going to happen to your cardiovascular system, etc. But let's say you all mapped out and it looks like, 60, 65, that's going to be really sort of not the time when you want to go beyond, What's that going to do to us?
I think that's a really interesting question, and I think it links to the problem that most people struggle with risk. That if you said to someone, there's a 5% chance you'll develop this or a 70% chance you'll develop that, I think most people struggle with that, certainly when it's applied to them.
Yeah.
And I think that's what the marker will be. I don't think it'll be you'll get a stroke at 65. I think it'll be here's a probability curve, and at 52 you have a 50% chance, and then you'll have a chance of this, and
Will you chance it? That's the question.
Okay. Will NICE be around in 100 years or to contribute to the debate, do you think?
Difficult to predict. I mean, we've been around for 20 years, which is quite a long time by the standards of arm's length bodies of government. So it'd be lovely to think that we would be. I think Dave's vision of personalised medicine is actually really quite soon. It'll become more and more extreme, and I think in the 50 years that Dave talks about, it will be, it could be highly personalised. But already things are getting, highly stratified, if not sort of fully personalised. I have to say, I don't find, and this is just a purely personal thing, I don't find the idea of, highly medicalised lives from the point of birth as necessary and attractive vision of the future. But it could well be the way we're headed. One thing I hope is probably not. It's not a prediction, but it's more a hope. I do really hope that the health inequality issues that Dave talked about, can be effectively managed. Because we are at quite an exciting point in terms of medicines and other health technologies. We are at quite an exciting point where we're seeing products starting to come through that really can extend life by many years. There's even potential cures. People are talking about products that are potentially curative, and it would be it'd be horrible vision to me that in 100 years' time, there's fabulous medicines for the fabulously rich, and poor provision for everybody else.
Okay.
It's such an interesting observation, actually, that the reason cancer deaths used to be an awful lot lower than they are now is because people used to die before the age where they started to develop cancer. So,
exactly. Exactly.
Okay, so I think this lady had a hand up in the front row.
So you've just talked about genetics and genomic medicine and personalised medicine and all that kind of stuff at the moment. I was just wondering what sort of bodies and organisations are currently around to kind of keep up with the social, cultural, legal issues that kind of surround it, and how we're going to be dealing with that in the near future.
Okay, who can take that one?
I don't.
It's a challenge. I mean, I don't think the framework is established at all. And what is it if, is your employer going to be allowed to ask for your genetic passport when you apply for whatever high-risk job on an oil rig or something? I don't think that's at all clear.
There's a very, very live political debate, and it's actually something our charity's looking at, is the relationship around data and information. So as you start to get more and more information, more and more treatment information, particularly once you put genetic information in there at the moment, it's not at all transparent what's happening with NHS data, its relationship with commercial organisations. And I think there's a lot of concern that our data is being used to support the development of a lot of those techniques and a lot of those treatments that have huge commercial benefit, but actually will the NHS and will the UK see some of that benefit, or will it just sort of be sucked away to people who know how to monetize data and information because we're not that good at it?
So I think lady on the side might have a comment or on this or a question.
So just to give some context to my thinking, I've spent some time living in Sweden, and I've seen some very, very sensible health policies around subsidised salads and rights to access and holidays during the summer. I've also, on the flip side, worked in UK private health insurance industry and tried to develop behaviour change incentives. So with that as a framework, I'd like to know actually from each of the four of you, if you had 1% of the GDP, what would you spend it on to actually improve health, bearing in mind that most of our chronic conditions and the spend we have at the moment is actually through lifestyle choices in the UK?
Crikey. Okay, well, I don't think I have to think about that, but I will go to Beate first.
Oh, thank you. All right. So, oh God, well, I think the obesity issue is really serious. So if I had that 1%, I probably would want to run a really comprehensive campaign and interventions and talking, we're talking preconception, counseling, the whole thing, to do something about that. Because I think that's ultimately what's not going to go well, and it will significantly impact on long-term health and everybody's well-being.
I think I would actually be really interested in starting to, if you could take 1% of that GDP, is genuinely devolve some of that decision making at a local level and empower people to understand how this works and to make real decisions. I don't think we have a particularly good track record in this country around making decisions on behalf of communities. And, I'm quite conscious, I'm sat here as a white, middle-class, cisgendered man saying what I think we should do with money. And I think it would be quite nice to put it more into the hands of community, by all means help to skill people up and empower them in how to make those decisions, and then say, actually, what makes sense for you? Is it about access to healthy food? Is it about support and education? Is it about supporting you caring for people with chronic conditions? Or is it about more GPs, more nurses, more doctors, or a particular type of drug?
Thank you. Nick?
I'm really glad I didn't have to go first on that one, because that's really difficult. I agree with very much the areas that have already been raised. I think the only one I would add would be whether 1% of GDP is enough, I don't know, but sort of trying to sort out the sort of interface with social care and work out sort of social care provision would be high on my list.
So if you are going to ask me, I would say that I would like to spend the money on making all children, not just children who are good at sport, find a love of some kind of activity which they can take throughout their life. I think that we have this in middle class areas of the country where lack of competition is not as important, so people can do it throughout their life. But I think engendering that love so that people want to keep fit and remain fit, to keep them out of hospital is a good thing.
How do you think that NHS will survive supporting an increasingly ageing population who have worse quality of life and require more medical attention intervention because it just doesn't seem sustainable?
Okay, is supporting the increasing number of older people sustainable? We've touched on this, but Nick, did you want to go? We've got a couple of minutes left, so.
Okay, yeah, I'll be quick. Yeah, I mean, I do think it's a challenge, and again, the types of work that we're trying to do through looking at sort of the health economic analyses of interventions. I think that's going to be a really big part of ensuring sustainable care.
Okay, thank you.
Yeah, I'd also slightly turn it on its head. I think there's almost an assumption that kind of money spent on the NHS is sort of going into this sort of infinite black hole of demand, whereas actually healthier countries tend to be more productive. If you look at the richest economies, they are often healthier populations. So there's an argument that says if you spend more and more of your GDP on health, what you get is people who are happier, healthier, better well-being, become more productive, become more economically active, and generally it tends to be an upward spiral. So, but I think there will be more pressures, and I think there's a political perspective of, do you increase funding and does that come from tax, et cetera, or do you have an increased role of private sector? Do you try and put more on the individual? And those are political decisions, and I think ultimately we as a country need to decide what kind of healthcare system we want.
I think we have to ask the communities a bit more, and for example, I remember going around in Spain where I saw lots of elderly people coming together around lunchtime, sitting in a canteen together, having a chat, you know, and they all looked fit and healthy to me. They'd been to the fish market before, so I'm having that one, but not that fish. And, you know, there was a sense of community established between people. And, you know, if I ask my friends, and we sometimes have these discussions saying, okay, when we're over whatever 70, we're just going to buy this great place somewhere, and then we'll just check in all there together, and then we'll help each other with our Zimmer frames, and then we do each other in when we feel it's been enough, you know. And I guess, you know, I mean, if you ask people, they don't want to live forever. And maybe we need to, I mean, I'm not suggesting we give them the opportunity, like, you know, but maybe we need to facilitate that discussion a bit more.
Okay. Well, I think that what's come through loud and clear from this evening's discussion is the importance of discussing and talking about these issues, all the different subjects that we've covered, so that people really know what's important, what's wanted, what can be done, what can't be done. I think we've come to the end of our time for questions. I want to say thank you very much indeed for all your great questions and your tough questions. And thank you very much indeed to our panellists, to Nick, to Dave, to Beate, for your excellent talks and contributions. So thank you very much indeed.